Hello, and thank you for joining us for today's TEDMED Great Challenges live event, part of the Great Challenges program sponsored by the Robert Wood Johnson Foundation. My name is Marshall Allen, and I'll be moderating today's discussion. I write about healthcare for ProPublica, a nonprofit news organization in New York. You can see our extensive coverage of patient safety issues at propublica.org. The goal of the Great Challenges program is to look at the most complex problems in health and medicine, issues that can't be solved with a magic bullet. Today, we're talking about a dire problem, the preventable infections, injuries, and deaths that too often occur as a result of medical care. Today, we will explore the reasons why the incidents are underreported and how patients can help. We will take questions from viewers on social media. We're on Twitter. The handle there is @TEDMED. Just tag your questions with the hashtag #GreatChallenges, and we'll do our best to answer them in the time we have together. Allow me to introduce our team members and our guests for today. Dr. Michael Victoroff is the Chief Medical Officer at LinksCare, a consulting company that provides tools to help providers and patients make safe healthcare decisions. He's a former Family Physician of the Year in the state of Colorado and a widely sought-after expert in patient safety and risk management. We're also joined by John Cox. He's the president and CEO of Visible Health, a company that's creating mobile and web applications to empower patients to better understand their conditions and their treatment options. We're here with Anna Hincapie. She's an associate professor at California North State University College of Pharmacy, whose research emphasizes patient safety demonstration projects. And finally, our guest for today's hangout is John James. John is a toxicologist, and he's the founder of the advocacy organization Patient Safety America, and he's also author of the book A Sea of Broken Hearts, about the death of his 19-year-old son after experiencing negligent hospital care. John is part of the reason we're having this chat today. He recently published a study in the Journal of Patient Safety that attempts to update the number of patient deaths due to medical mistakes. It was updating the original number that was published by the Institute of Medicine in the 1999 to Errors Human Report. We clearly have a lot to talk about today, and I welcome all of you on the panel to our discussion. In 1999, the Institute of Medicine estimated that 98,000 preventable deaths happen every year in the United States due to medical error. John, in the current issue of the Journal of Patient Safety, you published your own analysis and have that number ranging from anywhere from 210,000 to 440,000 patients dying a year. We've linked to your report, and I wrote an article about it for ProPublica. But John James, I'd like here for you to walk us through your study, and then I'd like the other panelists to share their thoughts about the frequency of harm to patients who undergo medical care. John, let's start with you telling us about your study.
Okay. I guess the genesis of my study and my motivation to do it had to do with seeing a number of things come together. There had been modern studies using the global trigger tool to identify adverse events and then identify whether they were preventable or not. And to me, a preventable adverse event is a medical error. And there were 4 of those, counting a pilot study from the Office of Inspector General. That, combined with a number of other studies in medical journals going over the quality of medical records, some physician attitudes about expressing errors to their colleagues and that sort of thing. I tried to factor all this in. I looked at, of course, healthcare-acquired infections, but I also kind of added in more than I think the Institute of Medicine did. They didn't necessarily look for errors of omission. They primarily focused on errors of commission. There are other kinds of errors too, errors of communication. There's also a lot of errors that are not evident until long after the hospital care is over. So if you look at those and try to understand those as best you can, and there again, I offer my numbers as estimates. There's certainly no pretense that they're precise. But when you roll all that together, the weight of evidence is that, as Marshall said, several 100,000 people have their lives shortened each year because of a mistake that was made while they were being treated in a hospital.
Now, John, I talked to several top patient safety experts, including Dr. Lucian Leap, who is known as a father of patient safety and was on that committee that did that Institute of Medicine report. I talked to them about your estimates, and they agreed that your estimates were within the bounds of reason. But can you talk about these studies? How did they actually identify cases where patients were harmed in the hospital?
Okay, well, they use something called the global trigger tool, which is a panel, if you will, of triggers that either a nurse or a pharmacist will cull through the medical records looking for these triggers. It might be a medication stop error or an unexpected need to treat an infection and that sort of thing. And they flag those, and then physicians look at the records and decide if an adverse event has occurred. And in some studies, they specifically render their opinion about whether that adverse event was preventable or not.
And I'm curious to hear what some of the other experts on our panel think about these estimates of the number of patients who are harmed every year while undergoing medical care. Dr. Viktorov, I know you have a lot of experience in patient safety and also risk management. I imagine this is something that you've looked into quite a bit. These estimates are astounding. I mean, when you talk about hundreds of thousands of people a year dying just in hospitals alone due to preventable adverse events, what do you think of those numbers? Are they overblown? Are they accurate? And just give us your thoughts on them.
Well, actually, my first instinct is to move away from the numbers because I think what all the number means to me, especially the deaths, is that it's a flag on top of an iceberg, and it says, dig here. Ultimately, we will refine. We'll learn better what these numbers are because our reporting tools will get better, and eventually we'll have something that I'll be passionate about maybe later, which would be a uniform taxonomy for reporting and studying errors. But just a short comment on the number is that the error is a tragedy, but in order to exploit it and make a lesson out of it that we can benefit from, we have to realize that it's simply a signal of some sort of a process failure or the human failure or some other glitch in our system that deserves study. So rather than making sure that we got the global count correct, what I would like to move to while we're working on that is to begin to parse it, the error data that we already have, and begin to figure out, well, what is it telling us about the kinds and shapes and types, causes, remedies, differences, similarities, and especially if there are places that stand out somewhere in the country where someone has figured out a way to prevent one particular type.
Yeah, thank you. Anna Hincapie, you study medication errors, and medication errors are among the most common, as many people know. What are your thoughts when you hear these estimates of the number of people who are being harmed?
Well, I agree with Dr. Viktorov that it's a big number, and perhaps we will never know the actual number until we figure how to measure errors. But I would like to add that errors not only occur during hospital care, and a lot of patients leave their pharmacies with the wrong medication, wrong doses, incorrect instructions. They don't know what to do with it. Those are potential errors that we may not be accounting for, which would make this number even bigger.
And John Cox, I wanted to round things out by hearing your thoughts about these findings.
I think I think what we tried to focus on is the patient side of that. I mean, obviously there are process breakdowns that lead to errors occurring, human error, process breakdowns. We try to focus more on the patient side of that, and specifically trying to help physicians better empower their own patients with the information that they need to ask the right questions. So, I think the numbers are certainly reasonable. They seem like at a personal level, the number that matters is one, right? If you've got one of those that affects you personally, and so we work a lot with individual doctors that want to try to make a difference with technology and kind of reach out and touch their patients one-on-one. So it's
Do you feel like with your experience with patients that they have a good understanding of the risks of healthcare?
I think I don't think so. I mean, I think that there's a lot of sort of historical and cultural reliance on care professionals to answer those questions for them. A lot of people patients want to kind of put their head in the sand and just kind of trust the system and trust the physicians, and most of the time that's the right thing to do. But you know, I think patients do need to be empowered. They do need to have the information, and I think they need to be able to rely on those consultants to provide them information to help them make their own choices, not necessarily make all those choices for them.
John, James, I want to come back to you on this topic. Why did you do this? I mean, why do you feel it's important to come up with a global estimate of the number of patients dying from harm suffered in hospitals?
Okay, Marshall, I'll answer that in just a second. Let me respond to something Dr. Victorov said. I very much agree with him that we've got to get the taxonomy of medical errors right. But I think even before that, we've got to break through and get better transparency into what's going on in hospitals so that we can actually begin to sort these things out. I work in the space industry, and we take our mistakes seriously, and they tend to be kind of public. And we dig down to root causes, but we've got to first of all acknowledge that an error occurred and be transparent about it. So the taxonomy, I think, will come after transparency. Now, my motivation to do this study was a kind of a coming together of the right pieces of information so that I could put together information from counts of adverse events and preventable adverse events, and then put that together with a number of other things, errors of omission, estimates of diagnostic errors, and so on, and kind of put these, if you will, all in a pile and just kind of look at it and see what I could best deduce about the number of errors. And I've been accused by some people, not anybody online, that I've exaggerated things, but there was certainly a way to work through the numbers and the information I had to actually make it sound a lot worse than I did in my article.
Now, several of you have talked about measurement. I mean, the saying goes that you can't improve what you don't measure. And in 1999, the Institute of Medicine called for a national system of error reporting and of calculating these harm events so that they are acknowledged, so that learning can take place. 14 years later, we still don't have a system like that in place. What from the panelists' point of view, what's been the holdup here? Why has it been 14 years since this landmark report? This is a widely known problem, and yet we still don't have an accurate measurement of the problem.
Well, that's one of my fetishes, and although I definitely agree with John that there's a cultural issue that makes having a wonderful categorization system moot if there's no numbers to populate it with. On the other hand, the partnership that you need is a change in culture with some sort of a collection basket, a system where people can drop their comments into, definitely including patients, doctors, and every one who's a witness. Just speculating, I don't want to speculate too much on why we don't have something, but I do know that a lot of folks, because patient safety is still a relatively young discipline, there is no global leader in the field. There are some tremendously influential and excellent organizations working in it. I myself, I was on the National Quality Forum Committee on Serious Reportable Events. There's the Joint Commission. There's a lot of organizations that are really interested, the National Patient Safety Foundation. But there is no organization with the throw weight to simply declare this is the collecting system. Several have tried, and most disappointingly, I think we had a lot of folks standing back waiting for the Agency for Healthcare Research and Quality to come up with a reporting system, which they have not been able to do so far for all kinds of reasons that are trivial.
Thank you. Anna, I believe you had something you wanted to add?
Yes, I would like to share that the World Health Organization actually has a global initiative on patient safety, and one of the areas they've been working on is How can we measure errors? However, they face the challenge that there is a lot of variation in how countries collect data, medical records, access to medical records, and even though we have this global initiative, it's very challenging to implement around the world.
So we received a question from Sarah via Twitter before we started the event here, and she asked what can be done to track errors that occur in an outpatient setting and not a hospital. Is that being done in any meaningful way in an outpatient setting?
Yes, indeed. Just to follow up on what Anna said, one of the organizational types that is doing a hugely vigorous effort to track and count errors is the medical malpractice insurance carriers. And I was just up in Canada, for example, where they have one malpractice company for the whole country. And we were talking about error reporting, nationwide, globally, and so on. I am not a fan of the World Health Organization International Classification of Patient Safety. I don't think that they have quite got it right in terms of good categories. But I think the idea that there are large organizations like one I work for in Colorado, there are probably 60 malpractice carriers around the country that are busy thinking about categorizing the data that they get from claims and reports. And there is some industry interest in harmonizing the different collecting systems among them. I'm sort of at the head of that currently. But this brings up another huge barrier that we really can't ignore, and that is that a lot of the very good data we have, both from in-hospital and from outpatient, is protected or needs to be protected from legal discovery because it has to do with lawsuits or claims or other sorts of legal complaints. And the companies entrusted with that data or the attorneys dealing with them are either legally forbidden to broadcast details about those things, or the hospitals collecting incident reports have serious risk, liability risk, if they share too much data about this valuable information.
Now, speaking of medical malpractice, Dr. Viktorov, one of our members of our ProPublica patient harm Facebook group, a woman named Veronica James, wanted me to ask what you all think about gag orders in malpractice lawsuits. I mean, part of the ability to collect information and engage patients in this process might include speaking to patients who have been victims of some type of a patient harm event. But as many of you know, when there's a settlement in a lot of these malpractice lawsuits, a condition of the settlement is that the patient sign a gag order that prohibits them from talking about these things. Veronica is one of the people behind a proposed law in New Jersey, the New Jersey Sunshine and Litigation Act, which would require the disclosure of judgments, records, and settlements concerning public hazards. As we consider engaging patients and as we consider improving patient safety, is it important to eliminate gag orders in lawsuits? Because not everything has to be kept hidden. Dr. Viktorov?
Well, yeah, you're sort of hitting that's my wheelhouse. I don't really think that makes much difference for this reason. It isn't the public reporting of one by one incidents, sentinel events, that is going to help very much in patient safety. Like I said, a sentinel event or some kind of a horrendous blunder is simply a flag that says you need to look here because it indicates that there are near misses and intercepted errors of all kinds that are similar to that blunder we need to look at. So the reason gag orders aren't very important to me is because I work for a malpractice carrier, and I am on the inside of all of the data about an event. And if I want to study or benefit from that event or even share information about it, what I'm going to do is aggregate that statistically and typologically with other things that are similar and talk to other companies, not about the protected confidential data about one incident, but about what we learn in the root cause analysis and what we can devise in terms of remedies that will help somebody else who doesn't need to know the intimate details.
John James, I'm curious what your thoughts are about gag orders with patients. I know you know a lot of people who have who care about this issue.
Yeah, I think Dr. Viktorov did an excellent job of commenting on the global value or not of gag orders. But I would emphasize that to those who are harmed and want to speak out about it, it is very important to not be gagged. So at each individual level, it really matters. Maybe not so much at the global level, but at the individual.
Anna, I'm curious in the arena of medication errors, what are the systems in place to measure? Are there any things that are being done on a global level or on an individual level that you know of?
Well, the Institution for Medication Safety Practices, ISMP, they have developed a reporting tool online, one for physicians and healthcare providers, and one for patients. And patients can go there and report the error that they feel, that they experience related with medications. And even though ISMP is not going to investigate to detail what happened, they're going to use that information to inform FDA and to create public awareness on what could happen with medication errors.
Now, John Cox, I know you're trying to think of creative ways to engage patients in their own healthcare. Have you thought of any ways, or are there any ways to engage patients to deal with this broader issue of patient harm?
Definitely. I mean, I just think a lot of the information, healthcare is very complex and care planning is very nuanced. I think a lot of that information gets shielded from patients, and I think that they show interest. You know, the physicians that we've worked with have talked about how their patients really express interest and gratitude when they take the time to educate them beyond just the basics of what they need to do when they walk out of the office, but drill deeper into their conditions and their procedures. And I think that the patient interest is there. I mean, you see that in, I've spent most of my time watching the technology markets, the healthcare technology markets, and so you see a lot of focus around patient technology, and the adoption isn't as great as people want it to be. And I still contend that a lot of that is going to come from the physicians, and so they need to be able, need to feel confident in being able to share that information with their patients and engage them in their care, and the patients will take the lead from the physicians.
What about something like another member of our ProPublica Patient Harm Facebook group, Deborah Van Putten, asked if it'd be possible for Medicare to send a survey to patients after they've been discharged or after they've had some type of a medical encounter. And the survey could ask, I mean, similar, we do patient satisfaction surveys right now. Could there be something added to the patient satisfaction survey that includes something related to patient harm, preventable adverse events, some way to gather data from patients? I see some of you shaking your heads. Does someone want to respond to that idea?
Oh, yes, hooray. Sign me up. I actually am working on trying to get normalization of a metric that I call visit effectiveness, which would be pretty much put together by an exit interview, kiosk kind of approach to everybody who is going into for anything greater than the flu shot. And that's because I work with patients who have very severe and complex conditions, and many of them don't necessarily experience fatal errors or sentinel events. But the routine experience, this is the under the waterline iceberg problem, the routine experience of a complex, difficult patient in the United States health system is to have an ineffective visit with a physician or the health system. Or something just doesn't get done right, or it's bungled or not communicated properly. So even if you don't even raise that to the level of an error, it nevertheless is a huge drain on efficiency, effectiveness, accuracy, and maybe even cost. And so I love the idea that we would be able to have some sort of a standard survey instrument that patients were expected to complete when they left their encounter, asking them, again, satisfaction, that's lovely, but this isn't satisfaction. This would be some more structured, specific questions about how did things really go here, and did you notice anything that seemed amiss?
When you think about a survey or any type of measurement tool, I'm wondering, a guy named Danny Long, who's another member of our ProPublica patient harm Facebook group, mentioned the problem of relying on self-reporting by hospitals to deal with these problems. So when we talk about doing a survey, or when we talk about whatever kind of tool we're going to use, does it need to be something that's independent so that we can trust the information? There's a lot of studies that come out about self-reported medical mistakes and things like that show that they're very rarely self-reported, and very little of that information right now is being audited. So, Anna, what do you think as a provider and someone who knows providers? Should we take this and make it some type of an independent reporting mechanism?
I think it should be both, because institutions, they need to collect information to improve themselves, but self-reporting will be affected by the culture and safety culture of the institutions. So if we don't start changing the culture of safety, we won't be able to get appropriate self-reporting. So I think both, it's a great place to start.
We have a great discussion unfolding on Twitter about our conversation here right now. I just want to read you a few of the comments. Gray House asked, how does one avoid quality assurance from becoming a witch hunt? And a user named Randy responded saying, 1 mistake equals 1 data point. It feels personal. 3 mistakes equals a trend. Solutions are possible. Dr. Victoroff, you specialize in analysis systems that support electronic medical records. How do we best identify errors that are trends versus errors that are maybe simple one-off individual mistakes?
Yeah, there are very few errors that are unique. Almost all of them indicate that there's a flaw in a process somewhere, even if it's just some individual person's thinking process. And I think we can't even answer that question scientifically until we have two things. As John had pointed out, a collecting system that allows us objectively to really understand what the universe is of mistakes, and a change in our culture about the value of benefiting from errors. And in fact, that the second is the really hardest thing for patients, doctors, workers, and for analysts. We can easily throw together a survey of some kind, and I don't really care who's the boss of the survey, but the problem that we have is we have a very strong culture of blame and shame and hazard whenever we either self-report, or what's even worse for me is when you report me. That's really uncomfortable. And the issue that I am struggling most with right now is learning how to go into organizations and trying to bend them around to a way of thinking that says mistakes are golden value for us. They are the shortest, quickest route to process improvement. I call it quality improvement by exception. You can study something for a year that's done right and not be able to come up with a way to improve it very much. But you just need to see one thing done wrong, and you get 10 ideas about quality improvement.
Well, and to kind of respond to that, we engage with thousands of patients here at ProPublica who have been harmed while undergoing medical care. And they say the number one thing, one of the things that they want more than anything else is just to know that the problem was recognized and that something is being done to prevent it happening again. I've found that patients are very forgiving when they know that the medical providers have acknowledged the problem, accepted responsibility for it, and are moving forward to address it. But unfortunately, that sounds like it's very rare. It doesn't sound like that's the norm. We have another question from one of our Google Plus users, Stacy Liu. This question's for John James. When discussing underreporting of medical errors, she says, I think the public assumes it's because clinicians try to protect themselves, which seems to be part of the problem. However, perhaps less attention is paid to the other problems you point out in your study, errors of omission and diagnostic errors. Are there symptoms or technology in place or in development that might help us out in these areas in the future? So in other words, is there a way that we can identify, or any system out there to identify errors of omission or diagnostic errors?
I think this could go back to the question about patient reporting. Sometimes it's years before a diagnostic error is realized. I just talked to a woman not long ago whose mother had died from bladder cancer, and her clinician was treating her for a urinary tract infection for years until it was too late and they discovered that the diagnosis had been wrong. So there needs to be a kind of a grand scheme of feedback to doctors that's not immediate necessarily, but maybe down the road a little ways, that, hey, the consequences of this 6 months after the visit or the hospital experience were not good. And something I would add to Dr. Viktorov's comments about, I think he's very much in favor of patients' voice being heard, but I would say that that voice needs to be heard not just when they're discharged from a hospital, but 6 months and maybe a year later, because there are things that you don't realize about your care until it's put in perspective. And so it's going to take quite a system to capture all this. One more quick comment. Within hospitals, there's wonderful information about who's effective and who isn't. Where I work, we are starting to do something called 360-degree evaluations. In the hospital setting, that would be nurses and doctors and administrators all evaluating each other anonymously, so that the fear of ratting on a colleague goes away. And then the administration would have to use the information they get to decide if somebody needs to be retrained or something more severe.
John Cox, did you have something to add there?
I was just going to say, I think including patients in that 360 review is an important piece as well. Otherwise, it's only like 300 or 320 or something like that. So, but I was going to say, I mean, it's also possible that a medical error could be subjective, right? It could be kind of in the eye of the beholder, and I think part of the problem with patients is a lack of context and a lack of information there. But if you take that 360 approach, and we do this, when running our companies all the time, if you take that 360 approach, you can get a better picture of the whole story. And I think on average, you start to see trends emerge from those kinds of conversations.
Thanks.
I'd like to
Go ahead.
Sorry, I didn't mean to jump in, but talking about diagnostic errors specifically, this is a good model to work on, because subjective data is incredibly valuable and good, and the subjective impressions of experts who work around you is really valuable, because it's most sensitive of all data. But something that we used to do back in the 1950s and 1960s was the latest really good data we have when we were doing autopsies in hospitals. And the data from back then, before autopsies became too expensive to do, was that between 25 and 30% of deaths in hospitals with autopsies had the wrong diagnosis at death. That not only means that we missed something really important, but also we probably were treating the wrong thing. That could have even contributed to the death. Now, the problem is that autopsy is very resource intensive, and we don't do them anymore. So no one knows in the year 2013 how many patient deaths in hospitals are due to accompanied by wrong diagnosis. The radiology gang says, imaging now makes autopsies less critical because we have all these ways of looking inside bodies, but no one can prove that. And so one really simple thing that we could ask for would be to invest a little bit more money in looking at hospital deaths and trying to exploit the knowledge inside them.
If anybody's interested more in the problem of autopsies, I wrote a story on that a couple of years ago about how hospitals bury their mistakes by doing very few autopsies. John Cox, let me ask you something. Here at ProPublica, I mentioned we take great efforts to engage patients in the journalism we do. We have almost 1,800 members of our patient harm Facebook group. We've had almost 400 people complete our patient harm questionnaire. And the patients make one thing clear: medical providers are not acknowledging their harm or seeking them to be part of the solution. So I know that you spend your time trying to figure out how to engage patients in their own healthcare decisions. What have you learned as other medical providers try and figure out how to engage patients? What have you learned about the way patients think that could help providers engage with them in a meaningful way?
I mean, I think it's a really, really hard problem. I mean, I think that they've got to be motivated to do it. It's not always health that motivates them. Sometimes it's economics that motivates them, or interest. But I kind of go back to this point again. I think that patients will take cues from their providers. If their providers are teaching them and exposing that information to them, being transparent and inclusive in the decision-making process, I think that they'll express the interest. It's just like going to school, right? If you've got a good teacher, you're going to become a better learner. And if you've got a bad teacher, it's going to be a less engaging experience. You're going to turn off and focus your energy and effort in other places. And
so Amy from Facebook kind of asked a question that's related to this. She asked, how can we educate patients in being better advocates for themselves and provide tools that help them ask the right questions? And equally important, how can we educate hospital care providers in listening and responding better to patient questions and in knowing the most common medical errors and how to avoid them? I guess let's just stick with the first half of that question, John Cox, because it relates to what you were saying. But how do we get providers up to speed so that they are doing that patient education?
Sure. I mean, I think it's just a question of time and the ability to fit it into the workflow of clinical practice. Clinical workflows have evolved over a long period of time to be highly efficient, given the tools that they have. People complain, a few years back, the complaint was all about paper records and moving over to EMRs. And the big problem is just trying to change something that's been kind of highly optimized over a long period of time to be a kind of a delicate choreography. And to ask people to take time and kind of learn new ways of doing things is very hard. With the economic constraints and the like. So I think the key is, at least when it comes to technology, is it's not a desire thing. I think providers want to do it. I think it has to do with coming up with creative and innovative ways to fit it into the workflow and make it seamless and make it just become part of the culture of giving medical care as a teaching experience.
Well, I know I talked to a lot of providers, and one of the frustrations they have is they feel like they're on an assembly line, right? I mean, they're just got people coming through. I mean, it's tough to think about how am I going to educate each of these people to be more aware of their health care. Kind of a related question that was asked on TEDMED.com. How can administrators acknowledge the dual pressure that they have? They have their pressure to prevent harm, but also to get the job done. And how can these administrators acknowledge the workarounds the staff often improvise to relieve the pressure, and also then encourage openness and evidence-based innovation? I guess the broader question there is, what can administrators do when they're trying to crank through as many cases as they can to keep revenue up while more and more patients are suffering harm? John James, I'm curious, from a patient's perspective, what would you say to that?
I think one possibility would be to have a certain number of, for lack of a better word, canned video presentations, so that, for example, if patients were deliberating about surgery or radiation and had a high PSA or something like that, or a prostate biopsy that was in question, the issues there are very complex, and a good doctor would spend maybe 15 minutes or more explaining that to the patient, undoubtedly in a biased way. Or breast cancer screening, the same kind of thing. So some of these standard things that patients don't understand the nuances of very well, I think need to be put into a video format, and actually the doctor doesn't need to be there. He tells his patient, go watch this, and then come back to me with your questions. Write down your questions and ask me the questions. There are no bright, clear answers here, and you have to understand that, but I value your questions. And I think if administrators did a little more of that, they'd find better efficiencies.
Dr. Victorov, I'm wondering what your thoughts are about that.
Yeah, this is a culture issue, and I think that we have a slew of remedies just for this issue about patient education. The internet is the most powerful tool ever invented to help patients collaborate with doctors and care systems. And I 100% agree with John. In fact, but you know, for even decades there have been videos and educational materials, and for my patients who mostly have very complex conditions, it only takes me 10 minutes on the internet to find downloads, guidelines, checklists, questions to ask your doctor, video, and also very valuable blogs and patient comments of people that have had the same thing or similar. So in a way, it isn't that the administrator sort of can possibly control access to that material. All they have to do is point the patient in the direction of it, and then give them a little guidance about how to filter out the nonsense. I have one more. I'll just slip this in quick. I have a radical idea. I get thrown out of hospitals all the time because I suggest stuff. And one of the things that got me thrown out.
I'd like to see that, actually.
I have bruises, I'll show. They even have a special door for me in some places. But one place I got thrown out of was where they asked me, well, what can I do to change the culture here in my hospital about gathering safety information? And I said, well, here, something I did in my own practice. When someone was able to catch me about to do something terrible, I would pay them $50. I just said, look, you know, I'm the senior person here. I can make really big mistakes. If I make a mistake, it's bad for everybody, okay? And I don't have eyes in the back of my head. So if you ever throw yourself in the way of me about to do something really dumb, I'll give you $50. There's a bounty on this. This is like coyote pelts, you know? So I have told hospital administrators, and this will work for patients too, you know, put an announcement over the the wash basin that says, if you seriously contribute to the interception of an error in this institution, there's money in it for you. We value that, and we want you to keep your eyes out. You know, watch me closely because I'm a great opportunity for you.
Now, with all due respect, I could see why they might make fun of you for that idea, but why would they throw you out?
Well, this one place, which I won't mention, the administrator, his eyes bugged out, and he said, my God, there would be so many reports, we would just go broke.
Oh, no.
So oh, well, okay, well, we can't have that. You know.
No.
I had no answer for that.
Wow. John Cox, what are your thoughts about the balance of the economic pressure with the need for patient safety?
Again, tough problem to solve. You know, definitely give me a shout when you've got that one figured out. I think it's just, like I said, it needs to become, I think you're starting to see it become more and more part of practice, especially with the younger generation of doctors. If you go and look at the medical schools, you see a lot more technology ingrained. We do some work with the University of California at Irvine, and they've embraced technology in their medical education at a very deep level. And you see the comfort level when you walk around those campuses. And again, I have a very technocentric viewpoint to this, and I've gotten thrown out of plenty of places as well for espousing that. But I think it helps. It's not the answer, but it's a way to help to take that wealth of information and to kind of put it in the hands of the physician there. And they've got to make, economic models will have to change, and care providers will have to make choices about that are difficult choices. But by pointing, I think that Dr. Victorov said, pointing patients towards the resources and pointing them in the right direction. That's exactly what we're talking about. That even that little nudge to say, hey, this is the right stuff to be educating yourself with, not the wrong stuff. Avoid this stuff, do this stuff. That even those little nudges are going to help, and it's kind of 1,000 cuts kind of thing.
Now, Anna, I wanted to pass along a question to you that we got from Google+. The question says this: the U.S. has projects like the HRSA Patient Safety Clinical Pharmacy Services Initiative that have reduced patient errors at discharge in hospitals and in clinics by adding pharmacists to multiple access points of patient care. How can we make this more widespread?
So I think one of the things that can be done is include pharmacists in to coordinate care. So pharmacists at this point, they are not seen all the time as a coordinator of care, but they could be, because they know what patients are getting from the hospitals. they know that patient will come back to get the refill, so they can follow up with patients and coordinate care better than what is done before. And I think pharmacists can gain trust and confidence so that patients feel comfortable asking questions every time they go to the pharmacy to pick up their meds. Unfortunately, at this point, some of the pharmacies, they look like a fast food restaurant where patients go in and out, pick meds, and that's it, all in 5 minutes. And there is not really the opportunity to take the time, talk to the patients, ask them back whether they understood about everything about their medications. And I think pharmacists can play a greater role in that contact with the community.
Thank you. Irene asks us on Twitter, how do we engage physicians? We talked about a few ways to engage patients, but there is a team of clinicians seeing these errors happen. How can we make it a safe zone to discuss and learn from mistakes when they happen? This kind of gets at that issue of hospital culture or healthcare culture, where there's really, in a lot of places, an environment of retribution when something goes wrong, where if someone speaks out, they're seen as not being a team player, or even worse. So what's the way to engage physicians or other medical providers so there's a safe zone, as Irene mentions, so that there can be learning from these mistakes?
Well, it's really important today not to overstate the culture of shame and blame. Although the plaintiff's bar is still very active, and although there is jeopardy available for people that get caught making really harmful mistakes, many states now where I've traveled, I'm very familiar with Colorado, where I can say we've almost eliminated the inhibition for reporting events in our local areas in certain contexts. And other states where there is a culture of collection and sharing, because either the malpractice climate or the Board of Medical Examiners or the local university has respun the orientation of the medical profession toward the value of collecting and learning, and the safety of having a sanctuary where you can report and discuss mistakes. I know that's not universal, but it's so widespread now and so good that I think it's important to balance our talk about the culture of complacency with a culture of openness also.
How widespread do you think that culture of openness is? When I talk to people who have some of the most progressive disclosure programs, like Rick Boothman at the University of Michigan, or Dr. Michael, or Dr. Tim McDonald at the University of Illinois at Chicago, or even folks there with with Copic in Colorado, they say that when they talk about their ideas, right now they're trying to expand these disclosure programs to other states and other hospitals in other states. I mean, there's still a handful doing it. I mean, maybe a few dozen, but we're talking about thousands of hospitals around the country. So do you really mean it's widespread that this is taking place, or do you mean there's a movement to change?
Well, actually, I don't know what I mean. How did we get people to reduce the number of cigarette smokers in the United States? We did that. I don't know how we did it, but the first thing that happened was it was okay to object, and then it was okay to be, a non-smoker, and then somehow or other, one institution, another, and we began to erode the problem simply by a mass effect. I think this is actually happening. We have some zones, and you mentioned several of them, where the culture has actually changed. And I have to say that the residents, the medical students, the trainees that I talk to, nursing students, and yes, pharmacists also, all kinds of health science students, have got a completely radically different idea about this than the old guys like me. And that's where the hope is going to come from. And it's amazing, what one little generation can do. I think this idea is catching on.
John Cox, what are your thoughts about this?
Well, I was going to say, kind of in the course of one of the things that we do is we do talk to pharmaceutical companies and device companies, and it's kind of a different level of participant in the system. And one of the things that we're hearing that's really encouraging is the idea of trying to bake patient safety initiatives into the services and the products that they offer. So, for example, using, again, technology as, information technology as a way to put a value-added service around a particular drug to raise awareness of the clinical protocols that are out there around that condition, or particular patient safety protocols with respect to a particular device or an implantable or something like that. It's just really great to hear these companies talking about that, because you sometimes can get a negative impression of device companies and pharma companies, kind of depending on who you talk to in the industry. And I think there's a great opportunity for them to be leaders because they do have the economic capability to do so. So just interesting thought.
Thank you. Yeah, we have another question from TEDMED.com where someone asks us, what about the good stuff? What progress has there been? John James, I want you to start with this because I know you study this very closely. Folks, John James, through his organization Patient Safety America, puts out a newsletter every month, I think he does it, of some of the latest medical research and studies around these problems. It's free, so I'd recommend getting it. So, John, I know that you follow these things very closely, but what about the good stuff? Like, where has there been progress in the last decade in promoting disclosure, in patient safety improvements? What have you seen, if anything, that gives you reason for optimism, or maybe some things that could be latched onto that other people just need to implement?
Well, in the context of many people, many MDs, and my own feeling is that this has been frustratingly slow, I think there has been progress. There are certainly metrics for quality. I think about things like the use of beta blockers for people in heart failure. That languished for a long time after the discovery in 1982 that these things were very useful and life-saving, and it wasn't until 2007 that they really came into full use for patients with heart failure. So there is progress. There are guidelines. Some are good, some are not so good, some are biased, but there are guidelines out there now that some physicians can rely on to get a handle on their how to care for patients if they fit within the scope of the guidelines. There's been some changes in the drug industry. I think I see a movement to more openness about side effects of drugs. You see that on your TV all the time, and there is certainly the opportunity for patients to report adverse events of drugs that probably wasn't there 5 or 10 years ago.
Anna, what about in the pharmacy world? Have you seen any improvements in patient safety that others could put into effect?
Well, actually, I would like to talk about improvements in the education that we're giving the students now.
Absolutely.
There is a more desire to involve quality and patient safety in pharmacist education, and not only that, but to create opportunities of interprofessional education on quality and patient safety. And this is something that had been done before in silos. Nurses would learn by themselves, pharmacists would do it by themselves, medical students by themselves. But now there is a more interest in putting all students together to learn this.
Great, thank you. What about Dr. Viktorov? Your thoughts on improvements?
Well, we touched on this very close. Anna mentioned something that I wanted to draw out a little. There's something in the Affordable Care Act that is underappreciated and I think misdirected, but I love the word, and that is a patient navigator. Right now, the ACA, I think of patient navigators as people who help you buy the right kind of insurance. That's lovely, but I think there is a much bigger role for a profession that I would even call a patient navigator, and anyone can play. A pharmacist is a navigator, a nurse, a care manager at an insurance company, a patient rep in a hospital, a primary care doctor. I do this as a family practitioner. I am a navigator. And I think one of the information tools that we have access to now that we haven't punched enough is the patient record. Because when patients have access to their own records, their own medical information, they start looking in what's in there, they become one of the main safety tools for the entire system. But they're the only one that in many instances that can reconcile the accuracy of their record with the truth. So I would say the partnership between whoever it is who is the navigator for a given case, the doctor, nurse, pharmacist, I don't even care, it could be your lawyer or your mother-in-law, and the access to the patient record in real time, actually looking it over, should be something that doctors ought to rejoice about, because it's now enabling a collaboration that will avoid several categories of errors that we've struggled with for generations.
Now we have about 4 minutes left, so I'm going to give each of you just under a minute to answer our final question. The TEDMED Great Challenges discussion center around issues that can't be solved with a one-shot cure. But we can certainly identify smaller, less magical steps or policies that might make a significant improvement in this area. So with so many critical issues driving complexity around this topic of patient harm, what are some of the best places to start focusing our attention? What are some of the things that we can do to see improvement in the short term, to build momentum and gain hope for the future and for more long-term efforts? Let's start with John Cox.
I think probably the easiest thing to do would be to start to form collaborative relationships with your patients if you're a physician or a clinician, and the opposite if you're a patient. So focus on communicating more, finding ways to do that, to share information, to share in the decision-making process, to start to educate both ways, educate more about patient, be more open about their condition and their concerns, and for the physician to be more transparent about care choices. I think if you start there, we have a more educated society and on both sides of the equation. And I think that everything kind of starts with education, and you'll see a lot of changes happening from the ground up.
John James, what are your thoughts? If you could just say one place where we could start right now, what would it be?
I would like to magnify something that Dr. Victorov said. I would give patients in hospitals the opportunity to see their medical records at least daily and go over them and sort of certify that they're an accurate representation, as they best understand it, of what happened to them. I think there's a lot of things that get left out of medical records or misunderstood and miscommunicated, and the patient is very valuable in that regard. And of course, if the patient's disabled, then their advocate is going to have to do that. But I think that's the one thing that would make a big difference.
Yeah, right now, again, I talk to a lot of patients, even some physicians who have been patients or caregivers, and it's not easy to access your records when you're in a medical facility. It's almost like sometimes a hostile reaction. Anna, if you had to say, what's the one thing that you would say we could do right now?
I would like to start teaching patients how to use the technology that they already use for other purposes, their smartphones, tablets, online, to prevent medical errors, and how can they use that more effectively.
Any ideas of how that could actually be done?
Well, for example, have applications on their phones that connect directly to the pharmacy, so the pharmacists can check up medication adherence. They can ask questions directly to the pharmacist. They can scan, for example, labels of the bottles, so they can show those labels to the pharmacist when they go to consults, those type of things.
Thank you. And Dr. Victorov, what are your thoughts about one thing that we could start doing right now?
Well, the easy thing is to speak up when you see a hazardous condition. Whether you're looking at the record, which you definitely should be doing, or you're looking at a stairway with a banana peel on it, I think the simplest thing to do is to just allow, facilitate, and reward a culture that says, like we do in the airport, if you see something that's suspicious, speak up. We want you to. We're all going to be glad. I'm going to be a patient there tomorrow, and I want you to find the banana peel.
And you might even give me $50 if I do.
Yes, definitely.
That would be fantastic. It looks like our time is up for the chat. Thank you very much to our panelists. This topic clearly affects all of us. And we'll talk about this subject for quite some time, and we still have a lot of other areas to cover. Don't hesitate to jump, for those of you who have joined us today, jump on the community pages and ask the questions we didn't have time to get to today. We may be able to address them in the future. And you can also join us on on Twitter at #GreatChallenges. We always welcome everyone's input, and we've really appreciated all the people who submitted questions today via Facebook or Twitter, the TEDMED website, or the Google Plus Hangout page. The next Google Hangout, Shopping for Health, will be on Thursday, October 3rd at 2 o'clock Eastern Time, and we will be joined by our obesity and childhood obesity team members and the Food Marketing Institute to discuss consumer behavior and health awareness inside the grocery store. Thank you to everybody in the TEDMED community, the team members, our guest John James, everyone who participated today and made this event a success. And thank you to the Robert Wood Johnson Foundation, sponsor of the TEDMED Great Challenges program. Goodbye, everyone.